All right. So I appreciate you coming in tonight for part 2 of the medical insights. Is it the medical? Oh gosh, hold on. Little brain fart for a moment there. There's one section that always screws me up. I want to make sure it's correct. I have the thing paused though. This is, yes, okay. All right, there we go. So this is part 2 of the medical aspects of individuals with chronic diseases and disabilities. Everything I teach you is taught to the Red Book. And what I mean by the Red Book is that's from the Springer Publishing or Connection, yeah, Springer Publishing Connect. And that came from what's called Certified Rehab Counselor Examination, the 3rd edition, not the 2nd one. And reason being is because the 3rd edition at the moment is the most up to date and it has the contemporary changes in accordance with the DSM-5 and of course the cultural changes of sexual identity. With that being mentioned, just a few disclaimers here. This group will not guarantee that you pass the CRC exam. You as the individual are ultimately responsible for your own commitment and time to study. This group is designed for professionals like you and myself to help one another grasp better knowledge of rehabilitation work and to collaborate together to build our knowledge and expertise towards becoming certified rehab counselors. All material, lectures, and information are not funded or sponsored by myself or any agencies themselves. There we go. You are required to pay for your own textbooks, flashcards, and learning materials. Any additional supplementary resources are made voluntary by you as the individuals and those who come into this room. Everything that I have here has been contributed by groups of people that have taken CRC before, and it's available and open to you. This group does not represent any major organization, school, or company or institutions, nor will it solicit any particular government or non-government interests. Again, everything attributed to this group is solely voluntary and has 0 mandates. However, the more you contribute, the more you add, the better you're going to be prepared for when you take the CRC exam. So if you're just joining in right now, thank you so much for coming in to do part 2 here. This is not going to be as long as the first one. And just as a reminder, I am not going to be covering the mental, a lot of the behavior disorders, only because the majority of us have had training and understanding mental and behavior disorders, like the classical symptoms, like, or the classical diagnosis, such as like bipolar disorder, schizophrenia, and stuff like that. That's not something I'm really touching on. I'm touching on the more of the physical and developmental disorders that aren't necessarily touched by behavioral health specialists that in the voc rehab role are very important. So if you're coming from a mental health background to rehabilitation, this is definitely something you want to take your extra time and effort to study and learn. And I do have some great resources at the end of the lecture here that are going to help you for that. And thankfully, it's open source and you can get off with it. So again, welcome for joining today. So to pick up where we left off on, we were talking about epilepsy. So we're talking about these neurodevelopmental disorders. Now, to be more specific, we're not going to be going into cerebral palsy or CP. Now, according to the book, cerebral palsy is not a disease, but it's a developmental disorder. It's considered a non-progressive and non-hereditary neurodevelopmental disorder. So if most of the time, what this also means is somebody with cerebral palsy is typically born with it. It may develop later in life, or it may show up in the early stages through infancy. And so I took an excerpt out of the Red Book because there are some factors to it. Of course, like any other major developmental diseases, there's no one root cause, but there are a lot of factors that can contribute to the development or the diagnosis of CP. And so I would encourage you to read this section here because these are things that can affect somebody both prenatally and at birth to later on develop cerebral palsy. Now, in the CRC, when we're talking about these specific types of medical terminology, they will ask you in terms of the medical terminology to say, what kind of rehabilitation plan is this? What type of cerebral palsy is being mentioned in the statement? Those kind of things. So For example, if the symptomology is saying, you know, if it's saying it's primary, and the question says, this person is of cerebral palsy has abnormal involuntary movement, muscle tones and gait, exaggerated reflex, muscle contractions, tremors, and steady gait and loss of coordination. Is this a primary or secondary of symptoms? They will want you to know. Or the question can be phrased as, these are all included symptoms of cerebral palsy except. So for you, as the candidate to sit for CRC exam, you do need to know what are the symptoms of different diseases as well as cerebral palsy. What are some of the functions of this, which in the book, it goes into more details. And of course, you can Google and research. And they may ask you the questions in terms of medical terminology about this here. One of the key things, though, I want to mention to you, or with that, is when it comes to cerebral palsy, it's a neurodevelopmental disorder that can affect different parts of the body or multiple parts. Does it mean it fully affects the brain? Not necessarily, but can it affect the physical function and the person to be able to interact? Absolutely. Depending on the severity of it, they may be either wheelchair for life, they may be on prosthetics, or they may just need certain physical things like physical therapy. You, as the rehab counselor, if you're taking the CRC, want to understand is that, do you know how to get somebody with cerebral palsy back to work or get him into a work environment, and what kind of work environment would they have? Anybody have any thoughts or questions on this section?
None.
Okay. Now, I was going to have this do it, but I don't have enough people for it though. But I would encourage you on your own study time, think about, if you're not working in the rehab role and you want to get into a voc rehab role, what are the types of programs that would be available for somebody with cerebral palsy, and at which severity? You know, that might be something to think about. So when you're ready to take the exam and they ask, you know, what are the interventions or what type of work placement or supported employment would a person need with cerebral palsy, you have a better idea of what we can do. We can do a shelter workshop, we can do supported employment, we can do X, Y, and Z. Okay.
Well, and
I'm sorry?
well, yeah, I had a quick question. So on the exam, if it does ask us how would we help them get employment? Will it be like they want us to do a short essay, like a little short paragraph, or will it be multiple choice? How'd that work?
So in the CRC, it's all multiple choice questions.
Yeah.
So you're not going to get a fill in the blank. You're not going to have a big paragraph. I have to know it's just strictly multiple choice. So the key here is, or the key takeaway here is, you need to understand enough of the terminology.
Gotcha.
And what the questions are asking to get the right answer, because there's always going to be just one answer. So for instance, the question can be phrased as, a person with cerebral palsy is going to the voc rehab counselor for services. They are experiencing, I'm just going to make up something here. The medical diagnosis shows that they have secondary brain damage. They have epilepsy. They have an unsteady gait and contracted tremors. What kind of service would you provide that person in terms of work? And they'll give you A, C, and D.
Gotcha.
Mm-hmm. Or they can also use these terms here, saying that this person is experiencing neuroanatomical, the topographical function is showing an unsteady gait, and ataxic cerebral palsy is including X, Y, and Z. Are these they may say, like, what is the primary, secondary symptoms, stuff like that. So really, when it comes to it though, you have to understand enough of it that if they ask you the question, you say, okay, I know that CP does X, Y, and Z. These are the primary, secondary symptoms. These are in terms as far as how it affects the body. These are the type of interventions for that. So when you get the question asked for you, it's not going to be a surprise.
Okay, gotcha.
Mm-hmm. That answer your question? All right. Definitely. So that's why I would encourage you is you're studying these various types of disabilities, also understand what type of programs are out there for them. What are interventions that are being done? Because in terms of the CRC, they want to test your level of competency, not only to treat or rehabilitate them, but also to understand the disability itself. Like, I got tripped up on a simple question about a certain vision disorder, and because I didn't understand the medical terminology of it, I misunderstood a term and I got the question wrong. I looked it up later, and it was a very easy question. Okay, now, I wanted to point out one thing as far as ADHD. A lot of people attribute it to ADD/ADHD. Now, believe it or not, according to the book and according to the DSM, attention deficit hyperactive disorder is considered a neurobehavior disorder, and don't confuse that with the attention deficit disorder. I'm not going to go into details because we hear so many things in today's news. There's so much research out there about ADHD that you can simply do Google. But if a question comes up saying that, and it won't be a true and false, it may say, you know, they may be describing symptoms of ADHD and says, is this a behavioral disorder, neurodevelopmental disorder, biological disorder, or an environmental disorder? They can come up with a question like that, and you have to be the one to pick it. So that's why I put it in red saying, no, ADHD itself is a neurobehavioral disorder, according to the DSM-5. So a word to the wise, make sure you understand the difference between attention deficit disorder versus attention deficit hyperactivity disorder. Make sense? Is this
Yes.
news? Is this a big news flash here? Were you aware that this was actually a neurobehavior and not just a regular like mental disorder? Okay. Well,
No.
I guess. Good. So I tell you one thing, for me, that was a little bit of a shocker. Because I thought it was just a regular mental behavior disorder, but it's not, it's a neurodevelopmental. So, and keep in mind too, ADHD can be a factoring, you can say like a symptom, or it's like could be a secondary of something else that's more serious, like let's say somebody with Down syndrome. They may have symptoms of ADHD. Autism, they may also have ADHD. So a lot of times ADHD is also comorbid with other diseases. So you might have questions that say, you know, a person who has autism and they're on the spectrum of X, Y, and Z are going to exhibit all the following to include whichever, or they may describe symptoms except they may say some other things like that. Or what is comorbid with autism spectrum disorder? ADD, ADHD, bipolar, or this. Most commonly, it's going to be ADHD. So that's how I would think the CRC would phrase it, that question out. Any questions about this one? Nope. Okay. So now, another section here I'd like to talk about briefly is the specific learning disorders. These are the disorders that people either mix words around, mix letters around, maybe they get confusion a lot, and they usually have a hard time mastering things in school because they have one of these things, which is dyslexia, dyscalculia, agnosia, and dysphagia. If you don't know what those terms are, I would encourage you to definitely look them up, because these are specific disorders that affect a person's learning ability in school. For example, if somebody is dyscalculia, they keep switching numbers around. So if they're doing mathematical equations, but they keep flipping numbers back, of course, they're not going to get the right answer. They're going to get a low grade. That in turn lowers their self-esteem. And as they get older, without early intervention, they end up with depression, or they end up resenting things in school. And who's to say they may not have a dyslexia too, where they confuse words and stuff around. Their reading and literacy is slower because they have to really effortlessly read on it because they keep flipping words back and forth. So in terms of the CRC, they may describe dyslexia, and they'll say, you know, this sentence of this includes X, Y, Z. Is this dyslexia, dyscalculia, agnosia, or dysphagia? If it's describing the stuff that you know of dyslexia, you're going to put dyslexia. If it's talking about dyscalculia because they're having problems with numbers, dyscalculia. And then of course you have nausea and dysphagia. So if you're not too familiar with those terms, definitely look them up. You will encounter, especially if you're working with transitional youth, you will encounter these people who have specific learning disorders. Welcome back. Some other notable chronic illnesses and diseases to also study as well. This came out the book was chronic pain, HIV infection, cancer, and diabetes mellitus. I don't know what happened there. Let me fix that. But nonetheless, I didn't want to go too much into these because we hear about this all the time. We see commercials about them. In terms of HIV, there's a lot of very effective treatments that delay the onset of AIDS, and sometimes they could be controlled. In terms of cancer, there of course are different stages. You have stage 1 through stage 4 of cancer. In terms of diabetes, there's 2 types. There's a type 1 where the person is born with, and then there's type 2 that the person, even though it could be technically hereditary, they acquired it over time. And so these here, I didn't want to go too much into it, only because we hear about this very frequently. But for you, in terms of studying for CRC, the key things they're going to want you to know is what population does it affect the most? Which stage, if we're talking about cancer, what stages are the worst? What can a person can and cannot do? If we're talking about diabetes, is it controlled or uncontrolled? And in terms of chronic pain, what is the level of their pain? Is the pain a psychological thing, or is it an actual chronic thing? So you, as the rehab counselor, if you're using the red book, the book itself goes into very fine details of what it is. And of course, like me, YouTube is your best friend. Did anybody have any questions or concerns regarding these sections, or do you feel like they can find this information pretty easily?
No, this stuff's pretty easy.
And waited. More than an hour later, the plan was set in motion.
Sherry asked Fred to go.
I heard something popping in. I had to mute it. I'm sorry. We'll do a quick fix here real fast. Hold on. I don't know what happened, but I think it's diabetes and mellitus. Yep. There we go. Sorry about that. Didn't realize there was a typo. Now, with terms of rheumatic diseases, we're talking about things about rheumatoid arthritis versus lupus. Now, I have a little video I'm going to share, which I think is very simple and makes it easy to explain. And of course, when you get the slides, you can also open up these videos yourself too and take a look. So the key thing though is with rheumatoid, it will affect the joints. It can cause disformity in the hands and feet. With systemic lupus, there's a more underlying condition because it's affecting blood, certain muscle tissues. So I'm going to go ahead and share this video real quick so we can see that. And then let me stop sharing here. And I'm going to pause. And we're going to share again. Come on. There we go. Share with sound. Can everybody see the video?
Yes.
They've confirmed that ear ringing is shrinking your brain cells.
Bones provide support for the body and aid in its movement. The place where two or more bones meet is called a joint. Joints may be immovable, slightly movable, or freely movable. A synovial membrane surrounds movable joints. Inside the membrane, synovial fluid lubricates and nourishes joint tissue, such as cartilage. Articular cartilage is a tough, slippery covering on the ends of the bones, which allows smooth joint movement. Joints give the body flexibility, precision of movement, and help in supporting the body's weight. Arthritis is any disorder that affects joints. It can cause pain and inflammation. Rheumatoid arthritis is the second most common type of arthritis. The joints most commonly affected are in the wrists, hands, knees, ankles, and feet. It typically occurs at the same joint on both sides of the body. It can also affect other organs in the body, such as the eyes, skin, heart, lungs, kidneys, nervous system, and digestive tract. Rheumatoid arthritis is an autoimmune disorder. This means the body attacks itself by mistake. In rheumatoid arthritis, the immune system attacks joint and organ tissues. Here's how it happens. The white blood cells of the immune system move into the joint. They release chemicals called cytokines, which attack the cells of the synovial membrane. These chemicals cause synovial cells to release other destructive substances.
So I wanted to do a brief pause. So this here is going into the neurodevelopmental issues of rheumatoid arthritis. For terms of CRC, that's not really that important, but understanding the joints that it affects, and more importantly, some of the long-term effects is what we're looking at, because when somebody's, let's say, for example, developing rheumatoid arthritis, they're going to have problems with some movement. They may, again, have joint deformities and things like that. So I'm just going to fast forward this just a little bit.
Treatment, the joint space narrows, and ankylosis can occur. Ankylosis is fusion or growing together of bones in the joint. This results in the loss of the ability to move the joint. There is no cure for rheumatoid arthritis. However, doctors commonly prescribe various combinations of the following medications that, when taken together, can reduce inflammation and pain and slow down joint damage. These include non-steroidal anti-inflammatory drugs, or NSAIDs, steroids, and standard disease-modifying anti-rheumatic drugs, or DMARDs. If standard DMARDs aren't working, doctors may prescribe newer drugs called biologics, also known as biologic DMARDs. Physical and occupational therapy, along with low-impact exercise, can increase muscle strength and help keep joints limber.
I want to pause here and go back just a little bit.
And
So, there we go. There's my pharmacology. So a question that CRC could ask you would be like, with somebody who has rheumatoid arthritis, which type of medication would you prescribe them, or would they be prescribed? And they'll give you maybe random drugs and then one right one. For you, in terms of CRC, if you know that to treat for rheumatoid arthritis, it requires NSAIDs like aspirin, Tylenol, ibuprofen, steroids, what is that name of it? Voltaren, and a few other ones, and standard biological. If you come across a question like that in CRC, you will know that it's going to be, has to be either one of these, or if they're listing these and one of them is not right, okay, then I know which the answer is going to be. So I have seen questions come up like that within CRC. So for you, you do need to know, what
What
are,
is,
I'm sorry.
what is,
Yeah.
what is the DMARDs again?
Let me take a look.
I'm sorry, I didn't know what that stood for, so.
Oh, no, you're fine. If I have it in here. Okay, I think they're the narcotics analgesics. I think that's what they're talking about. And they're in this family here. So,
Gotcha, okay.
yeah. So if in terms of the book, I would recommend going with the more common terminology. So like they may say things that are prescribed to a person with rheumatoid arthritis will be occupational therapy, analgesics, and what else? Being more simple. This here is it's giving you the example of how it affects the person. What are going to be the most common treatments? Don't get too caught up on the specifics of the medication, but like now if they say a person with schizophrenia is receiving medical treatment and they're having problems with medical adherence, what kind of antipsychotic medications are they going to take? Well, you need to know they're probably going to be taking lithium or something similar, a class 3, class 1.
Okay,
So as far as that NRADs, I would say go to the book for that one and make sure you understand these terms more specifically. So
thank you.
you're welcome. A good question.
Aren't working, doctors can increase muscle strength and help keep joints limber. For severe rheumatoid arthritis that has not been helped by other treatments, a doctor may recommend a surgical procedure. For example, a joint replacement procedure, also known as an arthroplasty, may be recommended. For joints that are difficult to replace, joint fusion, also known as arthrodesis, may be recommended. During this procedure, the joint is removed and the bones are fused together with bone graft. Another surgical procedure for severe rheumatoid arthritis is a synovectomy. During this procedure, the synovial membrane surrounding the joint is removed.
All right. So I wanted to share that with you as one example video to kind of help you, especially if you're not familiar with those type of physical or developmental rheumatic diseases, stuff like that. At least this way it'll give you some more insight to understand. Again, of course, the booklet, the material goes into more details as far as the treatment for it and as far as some of the factors for somebody developing that. And as you're aware, rheumatoid arthritis doesn't just have to happen at old age. It can happen with young age, especially if they have a immunodeficiency disorder and stuff like that. So one of the key things though is depending on the severity, where's chronic pain, where's my arthritis, where's it? Chronic pain. In terms of rheumatoid arthritis, you're also going to be dealing with people who may have depression and low self-esteem, because depending on the severity of it, they have to get surgery. That's going to stop them from working. It's going to stop them from rehabilitating themselves, being self-sufficient. So you as the rehab counselor, if we're talking about, in terms of age, who's at risk for it, you might want to study, for example, not in terms of age, but in terms of employment status. Usually within the first 2 to 3 years, 20–30%, 5 to 10 years after 10 to 20 years of onset. So it's a progressive disease. It doesn't go away. It will not go away. So you as a rehab counselor need to know, of course, not only how to help them self-manage the rehab, but also figure out what kind of jobs are going to be low impact or could be beneficial in the rehab process. Because CRC could ask you very well, what are some interventions that you can help them in their recovery or within their rehab process. Did anybody want me to share the video with lupus? No? Okay. You'll get the link for that too. I have the link in here as well. It talks about it. There's 2 ones. There's the one that's a visual aid. that's more just visualized like this one. And then there's also the professor or doctor that talks about it. And I think she does a really good job detailing it in simple terms. So, and just make sure you understand the difference between the two.
Is it a long video?
Let me see. I think it's about 5 minutes. I try to make sure when I find these videos, they're like 5 minutes, no more than like 10 minutes max. So let's take a look.
Do we have time to watch it?
Yeah, no, we do.
Chocolatier. All right, in this video, I'm going to talk about systemic lupus erythematosus, or SLE. So if you're following along with cards, I'm on card number 12. SLE is a chronic inflammatory disorder of the connective tissue, and it causes widespread inflammation as well as tissue damage. Now, keep in mind as I go through this information, I'm talking about systemic lupus and not discoid lupus, which primarily just affects the skin. So in terms of the pathophysiology behind this disorder, systemic lupus is an autoimmune disorder, which results in the production of anti-nuclear antibodies, or ANA. And this results in inflammation and damage to many organs in the body, including the skin, the lungs, the kidneys, and the heart. And just like other autoimmune disorders, lupus is characterized by periods of exacerbations as well as periods of remission. In terms of the risk factors, women are much more likely to get lupus. Onset of the disease usually occurs between the ages of 20 and 40, and race also plays a role. So African Americans, Asians, and Native Americans are at higher risk for getting lupus. Signs and symptoms of systemic lupus include fatigue, joint pain, fever, a butterfly rash across the face. So that's one of the hallmark symptoms of this disorder, as well as Raynaud's phenomenon. So with Raynaud's, you have vasospasming, so decreased blood flow to the extremities, to like the fingers. So those fingers become pale, numb, and cold. So if you Google Raynaud's, you'll see lots of pictures of like pale fingers, and you can imagine that they're probably numb and cold too. Other symptoms include anemia, pericarditis, which is inflammation of the membrane that surrounds the heart, as well as lymphadenopathy, so enlarged lymph nodes. In terms of the labs and how we would diagnose this condition, patients who have lupus will usually have a positive ANA titer, and they will also have decreased serum complement, so decreased C3 and C4. In addition, they'll have decreased red blood cells, white blood cells, and platelet counts. And then if their kidneys become involved at some point, then we would see an increase in BUN and creatinine as well. In terms of treatment, NSAIDs can be used, but we also usually provide immunosuppressants to patients with lupus because it is an autoimmune disorder and we're trying to suppress that immune system. So medications that fall within this class include prednisone as well as methotrexate. Hydroxychloroquine is also an effective medication for lupus. So hydroxychloroquine is actually a medication used for malaria, but it is also used for autoimmune disorders such as lupus. And then the provider may also prescribe a topical steroid cream for the rash on the face, for that butterfly rash. In terms of nursing care, in addition to providing these medications, you're going to really monitor for complications, including renal failure. And then you're going to provide some important teaching to your patient. So some of those key teaching points include avoiding UV and sun exposure to prevent skin damage. Also, the patient needs to really prevent infection. So they should avoid sick people and really protect themselves from getting infection. And then they need to take frequent rest periods as well because of that side effect of fatigue associated with systemic lupus. Okay, so that's it for lupus. When I
Not too bad, right? Not too bad at all. So, and there's an actual visual aid of that too, where they talk about it. Now, in key terms, when we talk about lupus, she's right, it is an autoimmune disease. CRC can ask you the type of medications that could be treated for somebody with lupus, and as well as potential work environment. So like she's saying, you know, they want to stay out of the sun as much as possible, stay shaded, stay warm, make sure they're preserving themselves from getting infection. And sometimes lupus may not be diagnosed until sometime later in life. So when it happens, there are going to be some chronic long-term effects on the individual with lupus. Where is my book? So with lupus too, they can also develop similar painful things like arthritis as well. So it really just depends, but like she said, same thing, NSAIDs, antimalarials, corticosteroids, they're treated very similar as we do with rheumatoid arthritis, but the key here is you need to know the difference between what causes the arthritis in its treatment versus what causes the lupus in terms of symptoms and its treatment. So if you confuse those, again, read those up. Those video aids will help you. They're very simplified. I keep it, like I said, within 5 minutes because I have a short attention span too. So you'll have that. All right. So now the other one is COPD, and I should have written this out here for you. So in terms of COPD, this is, where are you? Chronic obstructive pulmonary disease, or COPD. So the question may not write the whole chronic obstructive, it may just say COPD, okay? And I missed, there we go. In short, COPD is a group of diseases that cause airflow blockage and breathing related to problems such as emphysema, chronic bronchitis, refractory asthma, and bronchiolitis. If I said that right. Easy. Oh, thank you for sharing that, Sunny. I appreciate you. Thank you for sharing that, and you're willing to share that. If anything, if you would like to, you're more than welcome to have the floor and discuss about it and your experiences. I can give you that time right now.
I don't want to interrupt the class. I mean, we can wait. That's fine. I hate to have it on film forever or whatever. I know you're recording, so.
Okay, not a problem then. We can definitely discuss it afterwards, but I appreciate that. So, okay. All right, so moving on. So one of the key things out of the book, I think was the most important, it was understanding this here about goals 1 to goals 4 as far as the levels of classification for airflow limitation. That's going to be partly the big thing. So I did not personally see this in the CRC, but it's not to say this section will not be in the CRC. Okay, am I sharing screen? Am I just talking? Oh, God. Oh, I'm straight into it.
You are now. We can see it now.
I do that all the time. If I'm ever starting to go into something else and you don't see it, let me know. Say, Ken, share the screen. So, okay. So let me step back a little bit. So COPD is chronic obstructive pulmonary diseases. It's a group of different diseases to include things that are like asthma, emphysema, bronchitis, those groups. Depending on the severity of it, depends on how much their blockage airway is being, how much of the airway is being blocked. And we're not talking about sleep apnea either. We're just specifically talking about like asthma and restricted airflow while walking, talking, moving, any of that stuff. Now, this section here could potentially be on the CRC. I didn't see it when I took my exam. It's not that they say somebody else didn't see it either. So in terms of studying this, you want to understand that if they're talking about the global initiative for chronic diseases that a person has less than 80% of predicted this, you know that it means it's goal 1. If the question says the person has an FEV1 of negative 30%, predicted limitations, is that goal 1, 2, 3, or 4? You're going to pick goal 4. So this here, you have to actually study on it, okay? With that, we hear a lot in the news and stuff about COPD. I think they do a pretty good job just putting it in there. Of course, some of the factors to that too is cigarette smoking or secondhand smoke, people born with emphysema and asthma, chronic bronchitis, people getting older, those kind of things. So, and it can affect somebody's work ability, because if they were working in a construction environment and now they started developing asthma and they can't do the same work, they're gonna need something maybe indoors. So something to think about. But I would say in here though, definitely read about the GOLD levels and understand that more or less about COPD. Now, when it comes to burn injuries, I found a great video that explains it in details. And the best way to approach it or to understand it is the rules of nines. Now, I'm not going to go into full details of rules of nine. If anything, I think we can definitely watch the video on it. I think it's a little bit lengthy, but what you do want to know is what's the difference between a 1st degree, 2nd degree, and a 3rd degree burn. And then also how much of the body is burned and what's going to be some of the effects. Because a person can recover, but if the burn is fully 3rd degree and it takes their jaw off, they might be wearing masks and stuff. That might affect their ability to function too. So that's why burn victim is some part of it. But I would encourage you, review the video, understand the difference between the levels of degrees for burn injuries. And let me see how long the video is. Maybe we can watch it right now.
Try killing bugs the worry-free way.
It's frozen.
It's about a 12-minute video. Did you want to watch it?
Yeah, that's fine.
All righty, we'll watch it. It's really good. When I was in the military, I learned about it years back. It's been a minute, but studying for CRC, they could ask you questions about burn victims. So this is going to help you to comprehend the rules of nine.
Okay.
Live wild and free.
Welcome to the channel where medical topics are made easy. Today we're going to go over the rule of nines, which is used in burn patients as a quick way to estimate the total body surface area involved. This also pops up on medical and nursing exams, so it's good to know this topic. We'll go through a simple table, and there will be examples at the end, so make sure to watch the entire video. As always, you can find the notes and study guide for the video linked below. All of the videos come with notes, so make sure to subscribe to not miss out on those. As we mentioned before, the rule of nines is used in burn patients to calculate the total body surface area affected by 2nd degree and 3rd degree burns. This helps guide the patient's care, estimate fluid resuscitation, and determine if the patient requires care at a specialized burn center. The rule of nines only applies to partial thickness and full thickness burns, which are 2nd and 3rd degree burns. It does not apply to superficial burns, which are 1st degree burns. Let's walk through the table and diagram, and you'll quickly see why it's called the rule of nines and how it works. The rule of nines provides you with an estimated percentage of the body surface area for different body parts. So what do we mean by that? Well, let's take a look at the table. The entire head and neck make up 9% of the total body surface area. The entire right arm and left arm each make up 9% of the total body surface area. The entire trunk has a body surface area of 36%. The groin has a body surface area of 1%, and the entire right leg and left leg each make up 18% of the total body surface area, and this totals 100%. The easy way to remember this is to go in alphabetical order. First we have the A and H for arms and head, which are each 9%. Next we have the L for legs, which has a higher body surface area of 18%. Finally we have the T for trunk, which has an even higher body surface area of 36%. Once you have committed that to memory, the rest becomes easy. With the exception of the groin, you can see how the percentages are multiples of 9, which is why the rule gets its name. The rule of nines is used in adult patients who are not obese. When it comes to pediatric and obese patients, the accuracy of the rule of nines can be affected, which we'll cover at the end. Now you can see the table shows the percentages of entire body parts, so let's apply it to the front and back of the body. All we're going to do is divide each percentage in half. We know the entire head and neck is 9%, so the face and anterior neck make up 4.5%, and the posterior head and neck make up 4.5%. The entire right arm is 9%, so the anterior right arm has a body surface area of 4.5%, and the posterior right arm has a body surface area of 4.5%. The left arm is the same, where the anterior and posterior sides each make up 4.5%. The entire trunk is 36%, so the anterior trunk is 18% and the posterior trunk is 18%. You can break down the anterior trunk even more, where the chest is 9% and the abdomen is 9%. The groin is 1%. The entire right leg has a body surface area of 18%, so the anterior side is 9% and the posterior side is 9%. The left leg is the same, where the anterior and posterior sides each make up 9%. Again, you can see how the percentages for the anterior and posterior sides are multiples of 9, hence the name rule of nines. Let's look at a couple examples now. Try to figure out the total body surface area for each burn. The first patient has partial thickness burns involving the entire anterior chest and the entire anterior right arm. Hit pause on the video and figure out the total body surface area involved. We know the anterior trunk is 18%. Remember, the entire trunk is 36%, so just the anterior side is 18%. This burn only involves half of the anterior trunk because it only involves the chest and not the abdomen. So the burn to the anterior chest has a body surface area of 9%. Next, we have the burn involving the entire anterior right arm. We know the entire right arm has a body surface area of 9%. Since this burn only involves the anterior aspect, then it's 4.5%. So this patient with partial thickness burns to the anterior chest and anterior right arm involves a total body surface area of 13.5%. Let's look at one more example. This patient has a full thickness burn to the distal anterior left arm and a partial thickness burn to the proximal anterior left leg. Hit pause in the video and try to figure out the total body surface area involved. We know the entire left arm is 9% and the anterior side is 4.5%. Well, this burn only involves half of the anterior aspect, which would give it a body surface area of approximately 2%. Next, we have the burn to the proximal anterior left leg. We know the entire left leg is 18%, with the anterior aspect totaling 9%. Since this burn involves half of the anterior aspect, the body surface area would be approximately 4.5%. So this patient's burns involve a total body surface area of about 6.5%.
SGU put me in the best position.
The video is, as far as understanding Rules of Nine, is very informative. And I also sent some excerpts out of the book for you to read. So you have that. In terms of rehabilitation, though, one thing you need to understand, depending on the severity of the burn victim, if they're taking morphine to ease the pain, they might also affect their cognitive function. Most of the time, though, once they've had that recovery part, they're usually able to go back to work, unless it ends up in something more severe, something underlying. And of course, wound management is going to be the biggest thing if it's especially a third degree. Okay, so, but that's there for you. Make sure you understand about the first degrees, the levels of the skin where it's burned in, what does it affect, and what are some potential long terms, and also the terms of rehabilitation. And with that, that ends the part 2 of the chronic diseases and illness. Now, again, there was quite a bit of information that I didn't want to go into, only because we have the resources for there. But for you as a rehabilitation counselor, not only do you understand those physical and developmental and injury disorders, you also need to understand the mental part. That's also what separates us from a lot of our mental health clinicians, that we have to look at both sides of these disabilities. And in terms of the CRC, you don't have to be the expert of it, but know enough of the information so that when it comes up, you're at least familiarized with what they're asking. Let me stop recording.